Dr. Kaur, there is no voice.
Hello.
It's clear now, Doctor.
Oh, great, great. Thank you. Yeah, so there was some technical problem. Can you hear me now, right? You can hear me. Okay.
Yes, yes.
Okay. So let's start it again. Now the thing is that I am going to cover this endometrial carcinoma FIGO staging, which is 2023. Then what are the main points of postmenopausal bleeding? That we have a talk for this, right? We will cover those points as well. And quickly we will see how endometrial polyps can affect the malignancy potentials, right? And infertility also, which is the update in endometrial polyps. And then coming on to some of the oscillations, right? So let's start with the FIGO staging quickly. Now the changes here which have been made are that this in one stage one, now we have divided it into 1A, 1B and 1C, right? Previously it was 1A and 1B. Now in 1A, the disease has been limited to the uterus and the ovary. Okay, so an ovary also, there are certain criterias like how it can involve the ovary, that we will put it under 1A. Okay, so if the disease is limited to endometrium or it is a non-aggressive histology, you have to keep it in mind that if this comes in aggressive histology, the grade will be the next one. Okay, it is not the first A grade then. And in first A, only low-grade endometrioid carcinomas or non-aggressive histology, which is low-grade endometrioid. That's the non-aggressive only. So this will come, okay, with invasion of less than half of the myometrium, that we all know in previous staging system also, it was like that. And then half of the myometrium and with no or focal LVSI, lymphovascular space invasion, or generally we call this 1A as good prognosis disease, and we don't need to have be radical in this stage. The only hysterectomy and salpingo-oophorectomy, bilateral salpingo-oophorectomy, will be the curative form of treatment in this. Okay, so now 1A has been divided to 1, 2, and 3. If you will see, let's start from inside out, right? In this 1A1, only the endometrium is involved, whether it's a polyp or an endometrium, okay? Only the inner lining is involved in 1A1. And in histology, if we check, it is low grade, means it is grade 1 and grade 2 endometrioid carcinoma, which is low grade, okay? Grade 3 endometrioid is high aggressive tumor. So this we consider in high grade endometrioid. So in 1A, all are low grade endometrioid tumors. So non-aggressive histology, which is limited to endometrium. This is 1A. 1B will be if it involves less than half of the myometrium. And grade 3 will be if it involves ovary also. Okay. And limited to the uterus and ovary. It's not going here and there. Right. So now see, generally if the ovary is involved previously also, when it was in previous classification, it is the stage 3. But here it is the stage 1A3. But certain criteria are there to, to keep it under 1A3, like in the early stage. Even if the ovary is involved in this stage, the treatment is total abdominal hysterectomy with bilateral salpingo-oophorectomy, and no adjuvant treatment is required. Okay. If the endometrioid carcinoma is a low-grade endometrioid carcinoma and involving only uterus and ovaries. In ovary, the criteria will be that it is unilateral. Unilateral ovarian involvement is there, and it is not involving the capsule or ruptures the capsule, right? So, and here in the 1A2, thing to be kept in mind is that less than half of the myometrium is involved with no or focal LVSI. So these are the simplest version of the endometrial carcinoma, and the treatment is also simple. All right. Going on to the next slide. This is 1B1 and 1C. Here, if we will see in 1B1, just a minute, 1B and 1C, right? In 1B, what do we, oh, what's happening? It is running so fast. Okay. So in 1B, if the more than 50% of the myometrium is involved, right? We know that. Previously also 1A was having 1A1, 1A2. In 1A2, there was less than half of the endometrium. In 1B, there was more than half of the endometrium. And similarly here also, but there is non-aggressive histology, okay? And you have to just keep it in mind that LVSI is also insignificant in stage 1, okay? Coming to the 1C, the aggressive histological types. Just give me a minute. In 1C, the histology will be aggressive, means grade 3 endometrioid or serous or clear or mucinous, right? So these all will be there in 1C, which will be limited to a polyp or confined to the endometrium. Now you can see here that in 1B, the invasion is more than half of the myometrium. And in 1C, though it is limited to the endometrium, but the grade is higher for endometrioid, like grade 3 endometrioid, or the aggressive histological types, which are clear, serous, and others, right? So this is the difference between, this new thing has been added, that is 1C in stage 1 in 2023 FICU. Similarly, here in stage 2, there are A, B, and C, right? Now stage 2 was previously, it was also like, the invasion of cervical stroma. Previously also this was like invasion of the cervical stroma. And now in this, what changes they have made? That cervical stroma is involved, but there is no extrauterine extension or with substantial LVSI. What is substantial LVSI? Substantial LVSI when there are more than 5 blood vessels are involved. That is called substantial LVSI, right? Or aggressive histological types with myometrial invasion. Okay. Now, stage 2A, that is only cervical stroma involvement of non-aggressive histological type. Stage 2B will be substantial LVSI of non-aggressive histological type, means whatever we have learned here. Okay, if there is, like, suppose in 1B, there is LVSI involvement, which is significant, then we will upgrade it. Upgrade it to what? To 2B. Okay, that substantial involvement of LVSI is there. Okay, so if in 2C, the histology is also aggressive with any myometrial involvement. Previously in 1C, we have read that aggressive histological types are limited to, just I have to erase.
About the endometrial.
Yeah, just coming there. I have to erase this, otherwise it will keep on popping everywhere. Yeah. Yes, what are you asking here? See, this is a bit like you have to read it once or twice to, come into its form, basically. The thing is that, see, 1B, okay, I think I need to open the previous one. Do you have any confusion in this?
No, ma'am, it's clear.
It's clear? Okay, that's great. I thought you're confused about this. See, previously we had only 1A, 1B. You remember that, right? Previously, we have only 1A and 1B. Now we have an additional 1C, which include the aggressive histological type. Because in this classification, they have kept the main criteria of LVSI, morphological appearance, and histological appearance of the lesion, right? So now histopathology is also the important criteria to divide it into into different stages. So in 1C, there is aggressive histological types, and they are confined to the endometrium. If the aggressive histological types are involving any myometrium, then that is 2C. Understood? So in 1C, there is endometrium with aggressive histological types, and in 2C, myometrium is there with aggressive histological types. And in 2B, whatever myometrial involvement is there of non-aggressive type, but the LVSI is substantial, means more than 5 blood vessels are involved. So this we will call 2B. Okay, and the invasion of cervical stroma of non-aggressive, it is simply 2A, like before. Before we had only 2A, which was saying that, in this, the cervical stroma involvement is there. But now we have 2B and 2C also. Coming on to stage 3. Okay. In stage 3, previously also there was 3A, 3B, 3C, and 3C was divided into C1 and C2, right? So in 3A, in 3 basically there is a local and regional spread of the tumor of any histology. Here in 3, they don't mind the histology. It's just the spread. Okay. In 3A, previously there was the serosa and subserosa involvement. Now they have done it little like upside down of A1 and A2. Like in 3A, now they say that spread to ovary and fallopian tube is in 3A, right? In 1A3 also there was ovarian involvement. So how it is different from 1A3, I've told you that if, there are certain criteria of that ovarian capsule is not involved in 1A3. In 3A1, it is involved, and it can be involved, and the tumor can be bilateral, and there is, metastasis also present, means locally it has spread already. It has come out of the uterus, right? And there is substantial LVSI. Okay, means lymphovascular space invasion is also substantial, and the myometrial invasion is also more than 50% in 3A1. Okay, so there are these 4 criteria which differentiate 3A1 from 1A3. Means basically, if you will remember that 1A3 is the first stage, and no much collateral damage has been done. It's only that the uterus with grade 1 criteria and the ovaries are in. Okay, and all are low grade histology is there. Just remember that, right? And then in 3A2, involvement of uterine subserosa or spread through the uterine serosa. Coming on to 3B, the spread has been extended to vagina and the parametrium or pelvic peritoneum, right? We know parametrium is broad ligament, and pelvic peritoneum. So whatever parametria is there, broad ligament, tubo-ovarian ligament, and then pelvic peritoneum. So this all metastasis to these structures has happened by 3B. So in 3B1, previously there was no such 3B1 and 3B2. In 3A also there was only 3A involving the serosa and the adnexa. Now they have divided into, like, adnexa will be A1, 2 will be serosa and subserosa. Now 3B has also been divided into B1 and B2. In B1, there is vaginal and parametrial involvement, right? And in B2, the metastasis to pelvic peritoneum. So now mets have come to the pelvic peritoneum. And in 3C, there is pelvic and para-aortic lymph nodes. So this is to be remembered. In part 2 also you will get question from this 3C, like what it involves. It involves pelvic and para-aortic lymph nodes, and in that also, like, we divide C into C1 and C2. C1 involves pelvic lymph node. Now C1 again has 1 and 2. Those are for micromets and macromets. Now I don't think it is a good idea to go into deep details for part 3 people, but part 2 people can just read this thing that micrometastases are 0.2 to 2 millimeters, and the cells are more than 200. So you may get some SBAs from this, and isolated tumor cells are more than 0.2 mm and less than 200 cells, right? And similarly, the macromets will be more than 2 mm. So these 3 terminologies are there in pathological lymph node involvement. One is isolated tumor cells, then micrometastasis. What are macrometastasis? Not only for lymph node, but for metastasis. So in lymph node involvement, micromets will be 0.2 to 2 mm. Okay, and macro will be more than 2 mm in size. Coming on to the C2, those are para-aortic lymph nodes involvement. Okay, and till renal vessels, means up to renal vessels, these lymph nodes are involved, right? So they can be micro mets, macro mets. Okay, and apart from that, so this is the 3C. You need to remember that 3C involves pelvic and para-aortic lymph nodes. Here in the down area, I have copy pasted from the figure 2023 these criterias of 1A3, which is here. Like I have already explained you, I think twice, that no more than superficial myometrial invasion is present in 1A3. Okay, and absence of extensive or substantial LVSI, absence of additional metastasis. The ovarian tumor is unilateral, limited to the ovary without capsule invasion or rupture. So this is 1A3 criteria, and in 3A, all opposite to that will be applicable. Okay, so 3A has A1, A2 now, 3B has B1, B2 now, 3C has pelvic and para-aortic lymph nodes. Coming into non-aggressive histological types, they are low grade, grade 1 and grade 2, endometrioid, endometrioid, endometrial carcinomas. And aggressive histological types are composed of high grade EECs, that is endometrioid endometrial carcinomas, grade 3, serous, clear cell, undifferentiated, mixed, mesonephric-like, and gastrointestinal mucinous type carcinoma and carcinosarcomas. They all are aggressive. Now, this mucinous type, generally we have read that at all other places, it is like it comes in benign, okay, endometrioid and mucinous. But when it is of gastrointestinal origin, which is the mainly responsible for causing endometrial carcinomas, so this variety is aggressive form, this gastrointestinal one. All right, and for endometrial carcinoma grade is based on portions of solid area. So this is for MRCG part 2 people, that how the grading is being done. It is mainly because of the solid areas. In low grade or grade 1, only less than 5% or equal to 5% solid areas are there. Grade 2, 6 to 50% solid areas are there. And in high grade or grade 3, more than 50% solid areas are there, right? Now, let us quickly, I hope things are clear to the people. Or you want to, is it recorded? Or you want me to add something, or, be little slower, or you want, is it okay? However, I'm going. Are you people able to follow me? Hello? Is anybody here?
Yes, ma'am. Yes,
Okay.
ma'am, clear.
Okay, Pushra. Thank you so much, dear. Okay, so now, before starting this, I think we need to, be clear about the important points in the theory. I will be sharing the screen for that. Okay, just wait. Okay, so we will quickly revise this. Is it visible? My screen shared?
Yes. Yes.
Okay. So here we will go through the talk for the postmenopausal bleeding and evidence-based review. It was of 2012, right? So in this talk, there are some important points which you should all know. Number one point is that women with postmenopausal bleeding have a 10 to 15% chance of having endometrial CA, right? So if a woman present with PMB, you should know the number of 10 to 15% of turning it into endometrial carcinoma. And they should be, the pathway should be expedited. It should be a fast track pathway. Means within 2 weeks of referral, the woman should be seen, right? And cervical and vulval cancers, they remain important components of the DD. So local examination is very important in the woman with postmenopausal bleeding. Now coming on to this, again, that we need to exclude the cancers of the genital tract or precancerous lesion of the endometrium. So accordingly, we have to start the investigations from tip to toe, right? Vaginal atrophy can also lead to the postmenopausal bleeding, we know that, and also some benign causes like polyp and fibroid. Now, in postmenopausal bleeding cases, what is the prevalence of endometrial polyp and hyperplasia? It is 40%, okay? So hyperplasia is there in 40% cases, and endometrial CA 10 to 15%. Okay, so endometrial cancer is the most common gynae malignancy in UK. Now, risk factor, what are the risk factor? Obesity, unopposed estrogen means HRT, polycystic ovaries, nulliparity, and the most common symptom of vaginal bleeding is the most common symptom of endometrial carcinoma. Okay. And unlike ovarian cancer, endometrial cancer has a good part that it is diagnosed at the early stage, right? When they, and with the simple hysterectomy, the possibility of curative treatment is there. Hematometra can also develop, and a postmenopausal women with the complaint of discharge or brownish discharge, ultrasound showing hematometra, we can suspect, of endometrial cancer, as well as the cervical stenosis, which can also be the result of, either the atrophy or, senile changes, or the cancer of cervix, right? So the bleeding may originate from extragenital sites such as urethra and bladder. So when we do the workup for them, we examine as a whole. We take history, in which we ask for hematuria, and the stool, blood and stools, right? That's melena. Coming on to this, mostly the endometrial CA, the increase is higher as per the age. Like in less than 50% menopausal women, the risk is 1%, and as the age rises, the risk also rises. And more than 80 years, it is almost 25%. Postmenopausal bleeding and obesity has a risk of 18% together. And with diabetes, it is 21%, even more, right? So in obese women with diabetes and postmenopausal bleeding, that is 29%. If you have heard in a theory, in the post-graduation period, there is a corpus cancer syndrome, means if a postmenopausal woman is having obesity, diabetes, and hypertension, she is at high risk of developing endometrial carcinoma. So we need to be thoroughly investigating the woman. Similarly, now they have given you the numbers. So it is important for part 2 people to know the numbers and have an idea that it ranges in between that. If we combine the two factors, that obesity and diabetes and PMB, the risk is the highest. Okay. Now coming on to the accuracy of TVS for diagnosis of endometrial CA. It is a highly, non-invasive testing, which we choose as first line test when a woman comes with the, postmenopausal bleeding. The first line of investigation is TVS, but it is not the gold standard, right? Gold standard, if the question comes, then it is hysteroscopy. Now, what cutoff we take for the postmenopausal bleeding to go for further testing? If a woman with postmenopausal bleeding has a thin endometrium, like less than 4 mm, okay, or equal to 4 mm, so they are unlikely to develop endometrial cancer. The meta-analysis and the systematic reviews, they have happened, and this says that endometrial sampling is not recommended if patient has bled once and the endometrium is thin. Okay. So another investigation is this, the saline infusion sonography. Okay. In this, the saline is infused from the cervix into the uterine cavity, and ultrasound is being done. So it is better for recognizing the lesions like fibroid and polyps. Okay. But it is also, not so comfortable for the patient, right? So TVS is winning the case, like it is the main investigation which we offer. Okay. And but if patient is unfit for invasive or refused for invasive testing like hysteroscopy, Then we can offer it as a next step if we are not so happy with the TVS, or there is a recurrent bleed, or we suspect that in TVS it's not easily visible. Then we can go for saline infusion sonography. Now, coming to the accuracy of the endometrial sampling methods. Now, there are, how we can take the sampling. It can be without the hysteroscopic guidance or with that, right? So, the sampling is taken by Pipel's or Vebra device. Now, they say that Pipel is better sensitive technique, detection rate are more, like it is almost like 99.6%, which is quite high. So Pipel devices are preferred. Okay, so if the question comes with the comparison, then we can go for Pipel because the meta-analysis has already been done for that. Now, if somebody, in OPDs also we feel that, sometime the report comes as insufficient sample in endometrial biopsy. And a woman who has gone for hysteroscopy along with the biopsy, and in hysteroscopy we see that the inside of the cavity there is a atrophic endometrium, and it comes at inadequate sample. But we have confirmed with the hysteroscopy that endometrium is really atrophic, right? We can leave it. We can rely on that. But if it's not so, any polyp is there, or patient comes with recurrent bleed, then we may need to repeat the sample. Okay, if hysteroscopy has not been done, in that situation, if TVS is showing that the endometrial thickness is less than 4 mm, but we did the biopsy because she's bleeding, again she has come up with the bleeding, so we can also reassure the patient that nothing gonna happen, you can relax. But if she come back again, then we can offer her hysteroscopy. But in case we have already done hysteroscopy and still inadequate sampling is coming and cavity is all fine, we can reassure the patient. Okay, so these 2-3 scenarios are tricky one, and that you need to be clear about, and that's all. Now, how much accurate is the outpatient hysteroscopy to allow direct visualization of the cavity? It is useful for excluding the polyps and fibroid. Basically, vaginoscopic approach is there, and smaller diameter hysteroscopic systems are available. So it is feasible to do outpatient hysteroscopy. Inpatient is required only if it is impossible to perform. Okay, and once the scopy, like we can't do it inside the OPD, in the OPD, so we can perform inpatient hysteroscopy. Now it says that it is the golden approach to do the hysteroscopy to rule out endometrial cancer, because diagnostic accuracy is very good for endometrial cancer, not for endometrial disease. For the endometrial cancers, if a person is coming to you with other complaints, if there is a hyperplasia, if there is there is a polyp, so in hysteroscopy, the diagnostic accuracy of cancer is the most like we can rely on that, and we should use hysteroscopy for that purpose, for the diagnosis of cancer, right? And if a negative hysteroscopy comes, we can definitely rule out endometrial cancer better. Now, what are the diagnostic strategies for postmenopausal bleeding? So the stepwise approach is to be done. Like history taking should be good. Then examination part, we should rule out local genital cancers and extragenital sites also. Then we should offer her TVS as the next line. Though nowadays the risk factors are not included in the workup of postmenopausal women, right? We can get alarmed for ourselves that this can put her at high risk. But if in TBS the endometrial thickness is less than 4 or equal to 4, then we can rule out that those risk factors also, that will not pose an impact. Okay. And so TVS has more impact above the risk factor. Okay. Even if obesity, diabetes are present in postmenopausal women, age is also higher, but we will rely upon the TVS findings. And if TVS shows more thickness, then only we will go for further testing, not based on the risk factors. Now, this is a very important, it's a dilemma in gynae practice. What to do when one asymptomatic postmenopausal woman came to you for some other problem, suppose like some urinary problem or so, and you get to see her scan, in UK it doesn't happen that you get this scan unnecessarily, but at other places sometimes they get the scan done for some other thing, and this thickened endometrium comes in front of you, like it's more than 4 mm. What will you do? All the studies which have been done, they says that it's not recommended to screen women for the endometrial CA, right? So if a patient woman is asymptomatic and this incidental finding has come up, so we don't have to do anything. We need to see that if the woman is having any symptom, like if she comes with bleeding, then only we do the hysteroscopy and further workup. But one study has been done, and they say by Schmitz et al., they propose that hysteroscopy can be offered to women if the endometrial thickness is more than 6 mm. Okay, because they found that the commonest pathology was endometrial polyp, but we should not leave the woman if she has the ET more than 6 mm. So please remember this cutoff, as it may come as in the part 2 exam. What about the endometrial fluid if it has been detected? If it has been detected, that's no problem, no indication for further invasive testing. If in TVS, the thickness is less than 4 mm and fluid is there, we won't do anything. If fluid is there and the ET is more than 4 mm, then we will go for hysteroscopy. The same concept which we are having before. But this says that endometrial fluid can be a marker for the pathological changes. So similarly, in more than 4 mm, we need to investigate. Okay. Now coming on to the risk of malignancy in a non-endometrial polyp in asymptomatic postmenopausal women. Now these numbers are very, very important, and SBS comes on these numbers. That is why I'm covering this talk, because it's an important one, right? Now they say that if an asymptomatic postmenopausal woman comes, she has an endometrial polyp. So what will you do? Are you going to remove all those polyps? Or are there any criteria to consider polypectomy, right? So in this situation, it writes, the studies suggest, the multicentric study, and the conclusion is, it's a large study. So the conclusion is that atypical hyperplastic polyps were only 1.2% in asymptomatic women. In symptomatic women, it was 2.2%. So they did multivariate analysis, and they found that among these 1.2% atypical hyperplastic polyp, which turned into the carcinoma, what was the variable which was more prominent? So they realized that polyp diameter was the only variable which was significantly associated with the abnormal histology. Okay, so what was that diameter cutoff? In asymptomatic women, if the polyp mean diameter is more than 1.8 centimeters or 18 millimeters, then the follow-up and treatment for this polyp is important. Okay, it is to be done if the polyp diameter is more than 18 mm. That's not an emergency to remove it, but yes, follow-up is to be done and treatment is to be offered to the woman after explaining the numbers and the future of these polyps or what can happen and in which percentage it can happen. So atypical hyperplastic polyps were only 1.2% in the asymptomatic woman, that too which were larger than 18 mm. Mostly those were the polyps which turned into atypical hyperplastic polyp. So this is the chart for postmenopausal bleeding. How we will do the workup, we know by now that endometrial thickness on ultrasound, if it is less than 4 mm, there are no risk factors, no need for endometrial sampling, no further actions and discharge. If there are risk factors and repeated bleeding is occurring, and she's not even using HRT still, the bleeding is there and there is a fluid in the cavity which can increase the threshold of having the pathology in the endometrium. So if these irregular endometrium is coming in the TVS, so these are some of the indications in which older age group also, in which we may offer endometrial sampling to the patient. Okay. See here, the criteria, the risk factors includes the appearance of the endometrium. Okay, mainly the appearance of the endometrium. If it is irregular, if it has flared, and the age of the patient, considering because in 80 years it is 25% the risk of endometrial cancer. And if the patient is not using HRT and she's still having the bleeding, then that's a concern. We may offer endometrial sampling. In these cases also, if there is a recurrent bleeding and the TVS is showing less than 4 mm, so we offer the testing. Okay, and in testing also endometrial sample. More than 4 mm, offer endometrial sampling plus minus hysteroscopy. If the sampling is insufficient, but hysteroscopy shows that endometrial atrophy is there, then nothing is to be done. But if there is recurrent PM bleeding is happening, then we may offer endometrial sampling and inpatient hysteroscopy. Sufficient sample is there. Further management will depend upon pathology, right? So here it is the postmenopausal bleeding. There is a number which is to be remembered. Recurrence rate of postmenopausal bleeding in women with ET more than 4 mm was 20%. 20% women bled again when the ET was more than 4 mm. Okay. That's all, I think. Okay. PMB should remain the primary trigger for investigation of women on tamoxifen. Now, this area, we all know that it is selective estrogen receptor agonist, right? And it is it increases the risk of endometrial cancer in the postmenopausal woman by 3 to 6 fold greater incidence of endometrial cancer due to its weak estrogenic effect, right? It is a SERM. So the presentation of PMB require urgent investigation. And now the question comes like, is it, or should it be a routine to, offer testing in a woman who is on tamoxifen and showing thickened ET? Because mostly they will show thick endometrium, but is it the indication for testing in them? So the answer will be no, because only postmenopausal bleeding should be the primary trigger for investigation in women who are on tamoxifen. Now, what is the unscheduled bleeding on HRT? When we should be alarmed? If the woman is on cyclical HRT or continuous HRT, it is different for both. If she's in cyclical HRT, she'll get her bleeding, right? But if she get the bleeding in between the periods, that's a concern. In continuous combined HRT, it may take 6 months for amenorrhea to develop, right? If it is continuing after 6 months, then we need to investigate. For sequential regimes, abnormal bleeding may be. What are sequential? Like for 3 months together and then stop. So in sequential regime, be heavy or prolonged at the end if it is heavy bleed when we stop the HRT, or after the progestogen phase. Like when we continuously giving the HRT, which is carrying, first half will be carrying estrogen, then in second half there will be estrogen and progesterone both. New pack will be starting from estrogen again, and in the second half estrogen and progesterone again. So here, if after progesteronic phase, like suppose first pack has been started, and in after the second half of the first pack, if the bleeding occurs, that's a breakthrough bleeding. Okay, that's a abnormal, unscheduled bleeding. And if it occurs at any time, say it in estrogen phase also, it is happening in sequential regime, or after progestogenic phase also, like, or in between, then that's the breakthrough bleeding. So this is the definition of unscheduled bleeding in the sequential regime. And in continuous regime, if even after 6 months of giving the HRT, the bleeding is erratic and irregular, and it is happening. Bleeding on continuous combined regime should be considered abnormal if it occurs after the first 6 months and after amenorrhea has been established. Suppose if she has taken it for 3 months and bleeding comes. 3 months there was no bleeding at all. And then we say, is it abnormal? But we have read that, after 6 months of treatment, it should not happen. But if it is, the patient has already been amenorrheic for 1 year, menopause has been established. After that, if she is taking medicine, in perimenopausal phase, it's okay. But if once amenorrhea has been established and then she's taking the medicine, and for 3 months or 2 months, it's not happening, bleeding is not happening, and suddenly it has happened. So she requires endometrial assessment. Okay. So on continuous combined regime, after the first 6 months of treatment, if it is happening, or after amenorrhea has been established, then it is happening in both the situation. Coming on to the risk of atypical hyperplasia and the carcinoma, it's high. We know that, right? So multidisciplinary team should be there when the endometrial biopsy is showing atypical hyperplasia, right? And the decision for her management is to be taken. If she is a postmenopausal woman, LNG IUS, levonorgestrel intrauterine device, is an effective alternative, who are not fit for surgery. But if she is fit for surgery, then hysterectomy should be the plan. And if the endometrial hyperplasia is there, but there's no atypia, in postmenopausal women also, levonorgestrel is the first treatment to be given. Okay. Role of 3D ultrasound is not there. Now I will just tell you 2 or 3 numbers and we will move on. This is the another talk, which is the management of endometrial polyps in 21st century. So we have just read that, if in postmenopausal women, how we can have an approach towards the polyp. Now it is for the other people also. Okay. That what should we do when we see the endometrial polyp. Okay. So how it affects the fertility. First of all, this is important to know. In reproductive age group, if large or multiple endometrial polyps are there and they are contributing to infertility, as if other causes of infertility have been ruled out, then it increases the risk of miscarriage and it can contribute to infertility, and treatment can be provided to the woman. A woman has a better chance of becoming pregnant after polypectomy. This is just a talk. It's the supporting evidence for the polypectomy in infertile women. Now, what are the malignant endometrial polyps, right? If the polyps, prevalence of atypia and malignancy in the polyps, if a woman has, so what is the prevalence of that? Atypia is 0.8%, okay? And The malignant potentials are 3.1%. Those are quite high. But it depends upon the hysteroscopic markers, mean upon the appearance of the polyp also. Like if a polyp has irregularities, necrosis, vascular irregularities, wide thick areas are there, then we should take a histological diagnosis, and hysterectomy is also recommended once the diagnosis of atypical hyperplasia or carcinoma has been made in the polyp, right? Now, what is the treatment of the polyp? It is the removal. Okay. Effective treatment of abnormal uterine bleeding patterns, and if there is abnormal histological diagnosis, we should remove it. And we have just read that in postmenopausal women who are more likely that polyp can turn into malignancy when it is symptomatic, we should remove it. Okay. In asymptomatic, depending upon the size, we can remove it. Like if it is more than 1.8 mm, 8 centimeters, we can remove that. Current practice is to remove all endometrial polyps in asymptomatic postmenopausal women, and we have just read that in postmenopausal bleeding, the size is very important. So if it is more than 1.8, we should remove those polyps, right? But if she's symptomatic and have polyp, then it is of any size, we can remove it. Okay. This MCQ has come in MRCOG part 2 once, the size of the polyp. So this chart and that chart both have a clash, but the finding from postmenopausal bleeding endometrial cancer, endometrial polyps, the diameter and the treatment advice given in that portion is more accurate. Why? Because we solved that question at that time, and we found that the studies which are there in that talk, they outweighs the studies of this evidence of this algorithm, right? The polyp of less than 1 centimeter in premenopausal women, we can take this criteria of 1 centimeter because that talk doesn't mention about the premenopausal. So if the question comes from asymptomatic premenopausal women, and a polyp size is less than 1 centimeter, we can observe. So that is a common practice in our OPD. If a patient comes and says that this finding has come up in my ultrasound, so we ask them to just observe. If it give rise to any symptom like heavy bleeding, then we can remove it, right? Hysteroscopic polyp resection can be done, and if it is more than 1 centimeter in premenopausal also, we can remove it, right? In postmenopausal asymptomatic, if it is more than 1.8 centimeter, we can remove it. Otherwise, we can wait also. And in symptomatic, pre and postmenopausal, removal is the indication, right? I hope now you guys are clear about this. Am I clear so far, or you have any confusions? Yeah?
Yeah.
Okay.
Doctor, I have a question. You mean in case postmenopausal, symptomatic, asymptomatic, will remove it, whatever the size. So what is the meaning of 18 millimeter? 18 millimeter, you mean in the perimenopause?
In the postmenopause, see, here is this chart is there in front of you. Can you see this chart?
Yeah, I can't see.
You can't see?
I can. It's obvious. It's clear.
Yeah. Diagnosis of endometrial polyps.
Yeah.
Yeah.
I mean, we
So-
shall follow this.
Yeah, I'll just wait a second. I'll be telling you. Let me attach
Ma'am,
my
I think there is if there is endometrial atypical endometrial hyperplasia, the incidence of polyp is 1.8%, and if
okay.
with
Wait.
asymptomatic patient,
Wait, I will be showing
and
you.
with symptomatic patient 2% risk of polyp with atypical endometrial hyperplasia. What I understood.
Just wait, my dear. I'll be telling you this. That we are talking about the treatment of polyp, right?
Yeah.
So see here, this is the algorithm for the proceeding. How we will. This is the postmenopausal bleeding talk, okay? Which says that risk of malignancy in endometrial polyp in asymptomatic postmenopausal women. All right. So here, this is the prevalence of malignancy in endometrial polyp in asymptomatic postmenopausal, who is asymptomatic, who has no bleeding at all, but we are finding an incidental finding is there for the polyp. In the postmenopausal woman's ultrasound, a polyp has been seen. So they say that in this atypical hyperplastic polyps were only 1.2% in asymptomatic women, means the chances of converting it into the atypia of this polyp, which is converting into atypia, is lesser than the symptomatic woman. So in this study, they found that there are multiple variables which increases the these 1.2%. Who were they? Who were these polyps who which developed atypia? So in that they say that the size of the polyp when it was more than 1.8 millimeters. Understood? So if it was, see, it is written here. Yes. So it is written here that if the atypical hyperplastic polyp incidence was 1.2%. But there was a multivariate analysis that where were these polyps, or who were these polyps which developed the atypia. So they said that only variable which was significantly associated with an abnormal histology was the diameter of the polyp. So if the mean diameter of the polyp was more than 18 mm, then they had a higher chances of developing into cancer or the atypical hyperplasia. Am I clear now?
Yes, doctor, but according to the flow chart, they mentioned that symptomatic or asymptomatic postmenopausal will go for polypectomy.
Yes.
That's why I'm
here.
confused.
Yes. So in this, it is clearly said that incidental diagnosis incidental diagnosis in asymptomatic postmenopausal women could be safely restricted to a few selected cases based on the polyp diameter. Got it? So this is of postmenopausal bleeding talk, which says that in postmenopausal people, a woman, if the diameter of the polyp is more than 1.8 centimeter, we should offer them polypectomy, even if they are asymptomatic. Okay?
Yeah, millimeter,
And
you mean?
yeah.
0.8 millimeter.
Yes. And if the woman is having a polyp which is less than that size, we can just inform her that see the chances are there, but they are low, and we can follow you up, and treatment may require if you develop any bleeding or any symptom, or if the size increases. All right. And in the other talk, which is, I'll show you.
So, ma'am, basically, we are advising removal in symptomatic, be it pre or postmenopausal, and postmenopausal.
Yes. Yes.
Yeah. Okay.
In symptomatic post and pre-menopausal, we advise removal, right? We advise polypectomy. But if the woman is pre-menopausal, the cutoff which is given here is more than 1 centimeter for the resection.
Yes.
And the cutoff which is
Yes.
given here is more than 1.8 centimeter. Okay. Just give me 1 minute here to yeah. So are we clear? Shall we go ahead?
Yes, ma'am.
Yes, doctor, yes.
Okay. There is a very, very important, this endometrial hyperplasia, GTG is also there, right? I hope you all have read it and are aware of that. Though we are going to rebrush it very quickly. Or I think we should start with the case. And during the auscultation, because I have one auscultation which is from this only, this GTG only. So we can revise along with the case, and whatever points will be remaining, we can come back and revise through the guideline, right? Just one thing which is important here is the flow chart or the summary of this guideline. This algorithm of the management of endometrial hyperplasia, how will we manage that? Okay. So there are two conditions in endometrial hyperplasia. Suppose a woman has been diagnosed with hyperplasia of the endometrium. There is one without and one is with atypical hyperplasia, right? With the atypia. Now, what are the risk factors? Are there other additional risk factors present, like heavy bleeding, and patient is on HRT? Is there any obesity? Is she on tamoxifen? Is she anovulatory, like she's having PCOS? So these are the risk factors. So we have to rule out that. Coming on to the now, what can be the treatment for hyperplasia without atypia? First line is Mirena, we know that. Second line is oral progesterone. Okay. In atypical, it is for all. In atypical hyperplasia, it's a bit tricky, like if the woman needs fertility or she has completed her family. If she has completed the family, doesn't need fertility, then the treatment of choice in atypical hyperplasia is TAH plus minus bilateral salpingo oophorectomy. Now we can think that how can we conserve the ovaries, right? So here the explanation for that is consider ovarian conservation according to age, according to menopausal status and patient preferences. In addition to non-regression of endometrial hyperplasia or persistence of abnormal bleeding symptoms following the non-surgical treatment, a total hysterectomy may be indicated where there are adverse effects associated with medical treatment, concerns over compliance are there, patient preference, that is high level of anxiety. So I hope it's clear why we are conserving ovaries, because endometrial carcinoma is an estrogen dependent and these endometrial changes are also estrogen dependent. But the thing is that at present she has not developed any carcinoma. It is the atypia, like precancerous thing is there. So we can remove the uterus only and we can conserve the ovaries if the age is lesser, right? And she has not attained menopause so far, and patient wants to conserve the ovaries. Okay. Now, how frequently we should take endometrial biopsy? Okay, if we are conserving the uterus, like in atypical hyperplasia, if she requires fertility, then we offer her Mirena and we offer her 3 monthly biopsy. And at least one biopsy should be negative to offer her fertility treatment. And in endometrial hyperplasia without atypia, the Mirena should be inserted and endometrial biopsy should be taken every 6 monthly. And what can happen on these biopsies? What can be the findings? There can be regression. So if it is regressing, review the treatment, continue the Mirena for 5 years. Oral progesterone, we can stop after 6 months. This is important to know. And THPSO if bleeding is ongoing. Okay. If she is having continuous bleeding, breakthrough bleedings, still though she's regressing, but we will advise her total hysterectomy if the bleeding is continuous. If in the biopsy the changes are persistent, what will we do? We'll review her treatment. In all the cases, in endometrial hyperplasia, we will start the medical treatment if observation is failed. And if she is already on treatment, like in Mirena, on Mirena or on oral progesterone, then, and she's like, even 1 year has passed of medical management and she still bleeds heavily, then we will advise total hysterectomy and VSO. Okay. if the hyperplasia is persistent. Okay, so I'm sorry, I said it wrong. Bleeding is not the criteria here. If bleeding persists and it regress, the biopsy finding pathology regresses, but bleeding continues, we offer her to EH. Okay, and if the bleeding is, even if bleeding is controlled, but the biopsy pathology is persistent, then we need to offer her TAH BSO. When? Even after 12 months of medical treatment. Okay, it should regress by now. And in atypical hyperplasia, always advise total hysterectomy if it is persistent. If at 3 months the disease is persistent, it's not regressing, advise her total hysterectomy. Okay, and for the progression, always advise total hysterectomy plus minus bilateral salpingo-oophorectomy. And in endometrial this thing carcinoma, if it has been developed already, then we will manage it according to the cancer guideline, right? Now there are two factors like in endometrial hyperplasia, plain and atypical hyperplasia. There should be 2 consecutive negative endometrial biopsies at 3 monthly interval. Thereafter, 6 to 12 monthly EB and review. The biopsy should be totally regressed. It should be negative. There should be no hyperplasia, atypical hyperplasia, if we want to continue with the treatment or continue with the with the path we are going on, right? So 2 consecutive negative EBs are required at 3 monthly interval. Thereafter, we will offer her endometrial biopsy 6 to 12 monthly. Okay. And in endometrial hyperplasia, the follow-up is divided into 2 parts depending upon the BMI. If the BMI is less than 35, then the 2 consecutive negative EBs at 6-month interval, we can discharge the patient. If the BMI is more than 35, right, and patient is treated with oral progesterone, then 2 consecutive negative EBs at 6-month interval. Thereafter, annual EBs will be continued. Okay. And if she is on Mirena, okay, there is a point here to be seen. Review. This is the age point. I want you to just focus on that. Review the appropriateness of ongoing endometrial surveillance, continuation of medical management or TAH with or without BSO based on the factors such as baseline risk factor including BMI, AUB, symptoms, fertility requirement, compliance with treatment and follow-up. Medical comorbidities and risk-benefit ratio for TAH with or without BSO. If relapse occurs of endometrial hyperplasia or atypical hyperplasia, then advise total hysterectomy. Okay. So this is the chart which you should be knowing by heart, that what will we be doing next. So here for part 2, there are 2 different things to remember, that for endometrial hyperplasia and less than 35, we can discharge after 6 months. Not 6 months, after 1 year. 2 consecutive negative biopsies should be there. In more than 35, or if the woman is treated with oral progesterone, whether she has less than 35 BMI, then also, and if the BMI is already 35, then 2 consecutive negative biopsies at 6-month interval. After that, annual EBs are recommended if the BMI is more than 35 or if she has been treated with oral progesterone. Okay. So these are the 2-3 points which we need to know. Now I am coming on to our PPT again. I'm sharing this slide. Okay. So may I know who all are trying for part 3?
Ma'am, trying
Ma'am,
but not booked.
Not booked. Okay,
Yes, ma'am.
in the second window has already opened, I think.
Yes, ma'am.
That also you didn't get?
Already sold.
Already sold. Okay. That's chalo. You got extra time then.
Yes, ma'am. Within 30 seconds, all seats sold. UAE, even Egypt, all seats sold.
Okay. You're from which place?
I am from Pakistan, but I live in Qatar, ma'am.
Okay. So this happens, Bushra, right?
yes.
Yeah. So Bushra, this happens. This happened with me 3 times. And it was so
No,
pathetic to
I
sit
have booked
every
for
time.
exam. I
Who?
took it. Me.
Anna, Shaista?
Ma'am, Bushra booked, but Shaista not booked.
Okay, Bushra has booked already. Okay, Shaista has not booked. No matters. If you have not got the booking, you will get anytime sooner. Time will pass. Maybe you're getting extra time for something better, right? So you keep on trying, and you'll succeed in one go. Okay. With me, I did not get the booking 3 times. And when I got the booking, I was not prepared at all. And then within 2 months, I just geared up, and because we left a long time ago preparing, and then I did not join any course even, and then I started studying by myself, and I got only, you can say, 60, no, less than 60 days. Yeah, I booked on 5th December, and there was exam on 14th February. So I got 60 days. Yeah, more than that, in fact. So this was the scenario, and in that period I prepared. And I am of, I'm fond of teaching, so I'm here with all of you again, and I keep on coming and going, but this time I'm planning to be consistent in teaching, so that I can at least give you the benefit of whatever I know with me. So if, Bushra, you want to try this case, that's a very, very simple case of endometrial biopsy result. And we have just read
Yeah,
all of that. And you can give it a good try, right? You have November exam.
yes.
Yes. So go ahead, give your best shot, and I'm there to, give my feedback to you quickly.
Okay.
Okay, so let me put the timer. You can read the case. There's only one slide, that's very smaller one. So you can,
Yeah.
yeah,
Can I start?
sure, why not?
You want to put timer, ma'am?
Yes, I'm putting the timer. I've started already. You'll hear the bell at 10 minutes. You can use your own timer. And the next time I'll
Okay.
get the timer for you on screen. This time I
Okay.
wasn't that prepared. Yeah, so let's
Okay.
start, dear.
Yeah. Hello, I'm Dr. Bushra. I'm one of the doctors in the gynecology clinic today. Can I confirm your name and age, please?
Oh, yeah. Hi, doctor. I am Olivia, and I am
Okay.
40. Yeah, I'm 42 years.
Okay. If I address you as Olivia, is that fine?
Yeah, sure. Why not?
Yeah. Okay, Olivia. How may I help you today?
Doctor, a nurse has told me that my biopsy results are there. So I'm here to
Okay.
discuss with you. Yeah.
Okay. Surely, Olivia, I'll be discussing your report. But before that, is that okay if I ask you a few questions to know more about you?
Yes, doctor, but I'm a bit nervous. I wanted to know my results. Whether just is it fine, or is it something to worry about?
Yeah, I will surely address that, but I'll be in a better position to answer that maybe if I know some more information about you as we are meeting for the first time.
Yeah, okay. Okay,
Uh,
go ahead.
okay. Okay. Can I know about your period?
Yeah, my periods were quite heavy from last, you can say, 7, 8 months. I went to the GP. GP gave me some medicines to, stop the bleeding, but they didn't work well, doctor. And I was like, it never stopped completely. And they gave me some tablet. We call it, what do we call that? Some Tranixa thing.
Okay. Yes.
Yeah.
Connection.
So yeah.
Okay.
So those I used to pop in, 3, 4 times in a day, and then all this swelling and blotting came up, and I said I cannot take it much, and then he put me on some hormone also, like some progesterone hormone. Yeah, that's what I remember. I was taking
Mm.
that pill.
Okay. And first of all, I'm so sorry to hear about that. What you have been going through, Mrs. Olivia. Can I know that present tablets you are taking still?
Doctor, I'm still on those pills, but
Oh,
the bleeding was not stopped. So a GP sent me to the hospital, and they offered me the biopsy first. In the first instance only, they said this pill is not to be taken now, but I'm still
okay.
continuing it as I'm scared that if I will leave the pill, the bleeding will come up in an aggressive form again.
Okay. Yes. Okay. And are you up to date with the cervical smear?
Yes, I'm updated, doctor.
Okay. And do you have any foul smelling discharge?
No.
Okay. And can I ask you a personal question?
Yeah.
Are you sexually active?
Yes, doctor.
Do you have any problem like bleeding during or after sexual intercourse?
Um, no, doctor, I've never observed that. It's never there.
Okay, okay, that's nice. And have you had taken any other medications apart from these?
Yes, doctor, because this bleeding thing came up, I think I started on some medicines. My sister also, she's Charlotte. She also took the same medicine, and she was a bit relieved of the hot flushes and mood swings which she was having, and the similar symptoms I was facing. So I also started taking those weeds. These are some herbs, we use it as a tea.
Okay,
So yeah,
okay,
that is what I'm
yeah,
taking.
okay. And do you have any medical condition like high blood pressure or sugar?
No,
Okay, and are you allergic to any medication?
no, doctor.
Okay. In your family, does anyone have any cancer or any concerning problem?
Actually, my father, he has some gut problem. They says that it
Okay.
is related to some cancers in the families, but now he's doing
Okay.
well. All the screens
Okay.
has been done, and till date there is nothing like, which we can, but he has a gut problem. That is what I know. I don't know much of the details, but yeah, he's doing well. But doctors have told them that it is related with some cancers also.
Okay. I'm sorry to hear about that. But it's nice to hear that he's doing good. And have you been evaluated for any cancer, like because your father had?
um Not yet, though my father has asked me to, get the checkups done. But I am
Okay.
a working woman, and apart from that, my these health issues, they are not leaving me. So I'm so stuck over here. I haven't got the chance even to meet my family since 2, 3 years. So, you know,
Okay. Okay. And are you aware of a condition called polycystic ovaries, wherein there are multiple ovaries, multiple cysts on your ovaries, and you have problems to conceive and excessive hair with irregular periods? Have you had any such condition in the past?
no, doctor, my periods were quite regular, you know,
Okay,
but yeah,
okay then. May I know your weight to height ratio?
yeah, It's more. It's like 30.
Okay. And can I know your blood group?
It's B positive.
Okay. Any reservations in case if you need any blood?
No, doctor.
Okay. So, can I examine you in the presence of chaperone? I want to have a look at your tummy, and I want to do examine the neck of the womb and the vagina, which we call it as internal checkup with a small instrument. I'm sure it won't hurt you. I just want to see that your vagina and the neck of the womb are healthy.
Okay, doctor.
Okay. So now, Olivia, coming to your concern, I have confirmed your name and NHS number on the report, and the report says that. Okay, are you aware that why did we do this test?
Yeah, because they said that I've taken medicine, right? But it is still
Yeah,
bleeding in between
yeah.
the periods also. Like it is when I'm on medicine also, then also it's bleeding heavily in during my periods, not in between the periods. That's why they've offered me the biopsy, that why it's not responding to the medicine.
Yes. So let me tell you that the report tells that you know the lining of the womb. Let me draw and show you.
Mm,
This is the uterus. We called it as a womb, and inside this is the lining.
mm,
Uh, so the biopsy report shows that this lining is thickened.
mm,
Okay, and although it is not a cancer, but over time it can progress to cancer. And we call it as a pre-cancer stage.
mm,
Okay, and this is the lining is controlled by two hormones produced from the ovaries. We call it the estrogen and the progesterone. Whenever the balance between these two is means there is imbalance and there is rise in one particular hormone, estrogen, so the lining will thicken, and the estrogen can rise in many conditions, like when your weight to height ratio is high, and if you have taken medications for the symptoms for menopause, like hormone replacement therapy, and if you have had a condition which I described as PCOS, okay, and
okay.
I forgot to ask that. I'm so sorry. Did you were you pregnant before?
Yes, I have 3 children.
Okay, that's nice. Um, so this condition, majority of but the okay. So now coming to the report, when we examine these cells under a microscope, the cells will be like they are more in number,
Mm,
and the individual cell is abnormal.
mm-hmm,
Okay, and hence we term it as atypia. So it is hyperplasia because there are cells are more in number, and atypia because the cells are abnormal. Now
mm,
the risk of progress. Now we usually have two types. Okay, without atypia and with atypia. Now your condition, the progression to cancer is a little higher. So we would want to recommend a procedure um, uh, uh, to remove. Uh, I'm sorry, but is there somebody with you? You would like somebody to be with you?
No, doctor, you can tell me, but I'm really scared after hearing this that I have some
Okay,
precancerous.
I don't want to scare you because this is a really you know a manageable condition, and the only thing is that the surgery which we'll be offering will be a keyhole method. We need to offer you a surgery. We will be removing your womb, the ovaries. We need to still discuss about the ovaries,
Mm,
but for sure we will be removing your womb. It will be done by a keyhole method. You will be admitted on the day of procedure, and the sleep doctor will put you to sleep, and multiple small cuts will be made into your tummy, and a tube with a camera and light will be inserted through your cut in the belly button. We call this as laparoscope. Okay, am I clear so far?
Okay, yeah. But your
Yeah,
time is
so
finished already, but you finish the station, only then I'll be able to see. Yeah.
okay.
Mm.
And through another 2 or 3 cuts, we will be inserting additional instruments,
Mm-hmm.
and we will be taking off your womb.
Mm-hmm.
Now coming to the ovaries, okay, either we can conserve the ovaries or we may remove it. There are some pros and cons of the procedure. Like your age, as you said, 42. These ovaries will produce these hormones, as I said, the estrogen and the progesterone, which are important for maintaining your heart and bone health. So if we remove these, you might have some problem with the like increased sugars and hypertension or heart disease and thinning of bones. But in case we preserve, however, later if the risk of ovarian cancer in any individual can be there, we might need to offer a second surgery if in case any problem with the ovary arise. So it's all your decision. Okay, you might think about that. You can discuss with your partner about this. And after the removal of ovaries, we might need to give you hormone replacement therapy for that reason to protect your health. And however, there is a small increase with the breast cancer with the hormone replacement therapy, and there are some risks with the surgery, like some frequent risks like bleeding, wound gaping, shoulder tip pain or bruising, and there can be some serious complications like injury to the water bag, injury to the bowel, and we might need to open you up to repair this, or we might not be able to complete the procedure, and we need to do it under open method. And once we take the sample, the wound, we label it, and we send it for a testing. And let me tell you that the surgery will be done by experts who will be taking all precautions. And once we get the results, uh, then sorry, then once when we get the results, we can have a further discussion about it.
Okay.
Okay, and you need to just maintain a healthy lifestyle, and then your weight. Although I see that your weight to height ratio is absolutely fine. And regarding the medications, you told the herbal medications which you take. Actually, there are no data regarding whether they are safe, and so I may not be able to tell anything regarding that. But it is always better to take medications under supervision.
Okay.
And more, okay, and any more concerns do you have, Olivia?
No, doctor, thank you. I just want to give you a
Okay,
feedback now.
okay, thank
Yeah.
you.
Yeah.
I mean, I was so confused.
Uh, okay.
Please.
No. Dekho, Bushra, this is my, that is why I love teaching, because I love correcting, and I love, I would love to learn, love to see how you will learn, within these classes
Yes.
only. I'll make you so expert. Now I would just nicely want to give you the feedback over this, that you have to start the session with a full clarity of mind, how that clarity will come if you are so thorough with the guideline. I am going to give the summary of this guideline very soon in the group. Okay, my work is in progress, and you will
Okay.
read the summary quickly so that you are ready to go to the exam with endometrial CA, this hyperplasia summary. You know that when you know the guideline, you know how to handle the situation. Now in this thing, apart from that, even if you don't know anything, there are certain ways to go through and proceed in the station. Like you have read this. Now, what are the points to know? She is Olivia Smith. She is 42 years. She has a pupil endometrial biopsy which is showing atypia. And you know what are the chances of atypia to convert into the cancer? Within 10 years, 12%. Within 20 years, 20%. So just tell her the risk are more, like it's more than 10%, So that's more. And it needs an
Okay.
urgent intervention. So this should be your concern, that in the first meeting, whenever you are in Breaking Bad News station, you do not tell the patient about the procedure. You tell the patient
Okay.
about the procedure only in the follow-ups.
Okay.
Okay, your role
Okay.
here, what should be your role in the
Okay.
pre-cancerous stations or in the cancer stations or in any Breaking Bad News station? In cancer or
Okay.
pre-cancer especially, there are some buzzwords which you need to speak. Okay,
Okay.
buzzwords in the history, buzzwords in the investigations and examination, buzzwords in the management. If you will not speak those buzzwords are the marks. Okay. So
Okay.
first of all, starting from the your introduction, you have to keep a very comfortable and calm position firstly. Okay. Even I can't see you, but I can sense that you are in the stress of the station, that you have to complete it. Okay, that's why you're not able to complete it on time, because you are in a stress of completing the station. First of all, don't take stress. Go for chatting, talking, and managing a patient, not for completing a station. Okay, my dear? First thing, leave
Okay.
your stress. Try to shed off the stress, all of you. So first, you know that she's Olivia Smith. Hi, Olivia, how are you? Or just do not start it like this, because it's a partial Breaking Bad News station. So you can say, hello, I'm your doctor here today. My name is, your doctor is Bushra. Your name is Bushra. So you say, I'm Dr. Bushra, or speak your surname preferably if you're using doctor, right? Otherwise,
Mm.
mm, if you don't want to use that, like, what's your surname? You use that. Like I used to say, hi, I'm Dr. Kaur. You say whatever, they
Mm.
will not mind. Okay, and even if you can change your name and tell anything, so just say, I'm Dr. Bushra, doctor on duty in the clinic today. May I confirm your name and age? Yeah, I'm Mrs. Olivia Smith. So how would you like me to address you? Yeah, Mrs. Smith will be fine. Okay, Mrs. Smith, may I confirm your age as well? Yeah, it is like 42 years. Okay, thank you for confirming. Mrs. Smith, I can see that you had a biopsy. You said, uh, how are you here today? Like, you asked her, that you have her in the station only. It is saying that you have the biopsy reports with you. So you can just say, it shows your situational awareness. Yeah. So you just say, okay, I can see that you had a
Yeah, I asked, how can I help you today?
yeah, yeah. You asked that. I know. That's why I'm pointing that. So just say that I can see here that
Okay.
you had a biopsy 2 weeks back, and we have the result here. We have a result with us, and that is why you have been called. So before this, do you have any idea what are the reports about? One, in short, one is important to give in partial Breaking Bad or complete Breaking Bad. Okay, just say,
Okay.
do you know why? What are there in the reports? Have nurse discussed it with you? Because you have to see what she knows, and you have to go ahead of her. Whatever she knows, you don't have to repeat it at all. The purpose is just this. Okay. So if she says, yeah,
Okay.
she said that something abnormal is there. Oh, okay. So yeah, we'll go to it. Though I can assure you that it's not so abnormal now in this report, and we can discuss all everything about it just in few minutes. But would you
Okay.
mind if I ask you certain questions and then discuss your report? After that, we will definitely be discussing what next and what are the options for you. Are there any investigations to be done? In the end, I would definitely like to give you some written information regarding this, right? And so that it will help you. I will also give you our contact number to you, okay, for further assistance. So shall we start? So you have already made a very good agenda that even if you miss the written information, which is a must to give, which is a must to
Mm.
give in all the stations. So even if you miss this in the end, you have covered it and you get your marks. Okay, my dear. So this is how you have to start the lengthy stations, because then you are a bit saved. Okay. And after that, you say, when you have set the agenda, just tell her, Mrs. Smith, may I know, just quickly take the history, quickly. Okay. May I know why the biopsy has been done? Yeah, I had bleeding since so many, since a year. And okay, oh, I'm sorry to hear that. But can you tell me, like, did you take any treatment? Yeah, I took these medicines like Tranixa. Okay, okay, that's a good drug though. And other than that, were you put on any hormones? Because you have to be, you have to be fast. You have to be giving her the
Good.
leading questions. Okay. So
Okay.
just you ask that all. I'm so proud of you. You ask that all. But I'm saying just you have to be a bit quick and to be in that moment, so that the candidate, the role player also knows that you are very much aware and she needs to be faster to approach you. Okay, so you can ask, okay, so can you tell me, did you take any hormonal pills as well? Yeah, and are you still on? Yes. Oh, okay. And do you feel your symptoms are in control? No, I bleed so heavily. Okay, yeah. So, Mrs. Smith, apart from that, I would like to know whether you had your any abnormal bleeding between the periods. No. Are you with someone or you have a partner sexually? Are you sexually active? Don't say, don't mind me asking or anything. Just say, may I know, are you sexually active? Because it's a normal thing for them. And now in RCOG website also it is written that do not, before taking sexual history, don't signpost. Okay. Just quickly
Okay.
ask, are you sexually active?
Mm.
And she'll say, yeah. Okay. And do you have children? Yeah. Okay. How many, if I may ask? Yeah, I have 3 children. Okay. Were they normal deliveries? Or were they vaginal deliveries? Yeah. Okay. And what about, like, do you get any bleeding in between the period? No. Okay. And after sex? No. Okay. And what about your cervical smears? Were they all fine? Are you regular with that? Yeah. Okay. And Mrs. Smith, if I can ask, did you have any sexually shared infections in the past? Were you on any contraceptions? No. Any herbal remedies or any herbal pills or any medicines you are on, any long-standing problem? No, but I am taking those herbal things. Oh, may I know more about that? Who advised you for this? Yeah, that's my sister advised. Okay, but can we check those pills or check those samples, because they may contain a hormone which can cause this bleeding problem also? Oh my God, is that so? Yeah, this can happen. Okay. So I request you, when you come next time, please bring those pills so we can test them for, if it carries a high amount of estrogen. And I will advise you that please do not take that from now onwards, so that if it has that thing, so the at least we stopped. Yeah, that makes sense. Okay, I'll do that. Definitely. Okay. So Mrs. Smith, like you have to kill the thing there. You asked me, are you
Okay.
taking something? I said I'm taking herbal things. You addressed it later on. I heard that some pills can cause this. And do not ask about PCO. Okay. Just ask, were your
Mm.
periods regular? Yeah. Did you have any problem in the ovaries or egg formation? Or she'll say no. Uh, don't ask egg formation. Just say, did you have any problem in your periods? Or any time in their
Yeah.
life, the conceiving was difficult for the.
Or I think just irregular periods also, that should be
Yeah,
fine.
just ask, did you have regular periods? That's all. right? Children she already have. So nulliparity goes. Okay. Do not ask more about PCO. Do not give time. If it should be within seconds.
Yeah.
Okay. So gynae history you have taken. When did you have your last period? Okay. And this has happened. All right. And now you have to switch, go on to the medical history. You have already asked any medical problem you have, any cancers in the family. She said my father has a gut problem. Okay, may I know the details about that? I don't know. I said I don't know, but yes, they have advised me also about the cancer. Okay, Mrs. Smith, this is something we should be digging more into. And I would request you if you can ask them to fax you or message you, or WhatsApp you the stuff or mail you your father's report. I am going to quickly work on that and we can find the relationship and we want your safety, see. So we want you to also get your checkups done if it has been said that, it can cause cancers. That's something serious. Oh, yes. You have to be with them. You have to talk to them as a family, like, you have to do a holistic approach. You can't leave anything unhandled or unfolded, okay? You have to be a very, very safe doctor and a doctor who is empathetic, a doctor who wants their wellness, and it should be visible in your voice, on your face. The warmth should be in you, okay? So just say, okay, after that, any surgeries in the past, just a tick to you have to mark a tick. So she'll say no. Okay. Blood group and blood transfusion is not required. You can skip those questions. Drug allergies you asked. Okay. And then you can tell her you asked about the cancers. You can now you asked about you have to ask about the personal history, because smoking is a risk factor for endometrial atypia and for the cancer. So you can ask her, do you smoke at all? Only that smoking is related to endometrial cancer. So even if the time is less and that station is a bigger one, you have to cover the whole MDT thing and all investigations. So you can just cut down short and you can ask, do you smoke at all? And do you feel any mental health issues, or anything which troubles you? Do you feel stressed? Anything you can ask, just a single liner, just to cover the mental health part. It is so much advisable. And do you feel supported at home to rule out DV and MH? Mental health and domestic violence is to be ruled out in all the cases. These are the latest recommendations in the talks and in the RCOG website also. So this you have to ask in one line, any one liner you can choose. And then, what is your BMI? It's 30. Oh, just don't say it's perfectly fine. No, she's too much overweight. Oh, okay, I can see that. It's higher. Because WHO has certain criteria, So on these criterias you comes in overweight, and I could say that I can say, just at the borderline of the overweight and obesity. So I think here, if you work on yourself, may I ask if you're trying any exercises or any diet? She'll say, yeah. Even if she's already trying, you have to appreciate her, right? Because you are going to tell her the importance of losing some weight to reverse this condition. Even that can also reverse the condition and reduce stop the progression. So you can say, oh, that's so great to hear that you're trying. But if you will ever find any difficulties, we can help you. We have the helplines which can guide you for the exercise programs, group exercise programs, and diet clinics as well. Yeah. So please reach on to us. We are always there to help. Because why I'm insisting on that, Mrs. Smith, the problem which you're having, this bleeding problem, it can be very well controlled once the weight comes in normal position. Yeah. Okay, so coming on to your reports now, examination you can definitely avoid, because the biopsy has been taken already. You have the reports, so focus on that mainly. Otherwise, you can always tell that, okay, I'll ask my nurse to take your blood pressure because we want to rule out her hypertension. So I'll ask my nurse to take your blood pressure. And after that, I would like to examine you as well for the size of your womb, and to see from down below if there is anything which can bleed. heavily, which can add into bleeding heavily. Okay, just speak like that.
Okay.
And just don't to go for PSPV. Just say that, I would like to examine you from down below. Yeah. Just to see if there is any mass or, size of your womb. And if there's anything which can add into heavy bleeding. Okay.
I
Yeah.
think we could avoid here as well, right? Because he is coming with biopsy.
Yeah. That you can always avoid.
That also will be fine.
Yeah. You can avoid.
Okay.
Yeah. But still, if there is written like here, information gathering, communication with patient safety, applied clinical knowledge. So there is like information gathering is there. So examination is a part of information gathering. So you can just speak a word that, I would ask my nurse to have your blood pressure, and then I would like to examine you also from down below, just to see see if there is any mass or what's the size of the womb or any other source of bleeding. Yeah, if you don't mind. And there will be a chaperone present. Yeah. She'll say, okay. Yeah. All right. Apart from, if she'll say, no, I don't want examination and it has been already done. Why do you want? Sometimes the role players are really fussy and you may get these kind of, then you say, okay, I respect your wish, right? We won't do it. First, let us discuss your reports, and in the next meeting, if we will find that examination is important, then we'll do that, right? Okay. Yeah, it's fine. Then you come on to the reports now. Okay, Mrs. Smith, I've confirmed your name and NHS number. And these reports very well belongs to you. These are the biopsy reports. So it says that the okay, the biopsy report shows that the lining of the womb, it is thickened, right? And thickened to an extent that it can turn into cancer in near future when we don't know. But I'm sorry to tell you that it's a precancerous report, Mrs. Smith. Just take a break. Bushra, you need to take a break after breaking any news or any report. Any report, whether it's a H-mole report.
Precancerous also?
Any report you tell the patient. Any report I say means any report which is away from the usual. Okay. Suppose it's a H-mole in a pregnant patient. Just stay silent for count in your inside you 1, 2, 3, 4, 5, and then Mrs. Smith, I can see it's a bit distressing, but believe me, we are here to help you. Yes, we need to take some action here because we cannot wait much in these kind of situations. Do you want to know more about it? Shall I explain you in detail? Yeah, okay, tell me. Why this has happened with me? Mrs. Smith, there are many reasons that can lead to these kind of findings. One is definitely the weight part that can also contribute. Don't say definitely, okay? Otherwise they start blaming. So they say non-blame approach should be there. So just say that, yeah, like high BMI can also contribute to that. Okay. And if, sometime your periods are so irregular, that's not the factor in you, but there are many other causes as well, right? So now the thing is that how we should proceed further. Would you like that I should explain it now, or do you want your partner to accompany you? Okay, just ask that. It's a good understanding between you and your patient. You can wait. It's not something. Yeah, no, you can tell me. Okay. Yeah, sure. Mrs. Smith, first of all, I would like to tell you that we need to expedite the things within 2 weeks. I will be, sending the case to the team of the doctors, But before that, who will decide the best management for you in this situation? Oh, what management? What kind of treatment you want to give me? Yes, Mrs. Smith, coming on to that. We want some more investigations to know better about this situation, this report, because this precancerous report has a rate of, around 10 to 20% chances of turning into cancer in next 10 years, or where maybe some years have already passed, so we don't know. To be on the safer side, we will put you under some more investigations. Just tell her about the, I'm sure that ultrasound has already been done for you. Yes, it has done. Okay, I would like to review that as well. And, there is a camera test which we offer once these kind of reports comes. And at least mention hysteroscopy, okay, because that's the gold standard. You say, and we can do it in the outpatient department only, and we need no anesthesia generally for that. But what we do, we pass a camera from down below through your neck of the womb, inside your womb. We see if there is any lesion, any mass or anything, or which can give us the suspicion of something sinister. So we can retake the biopsy from that lesion. And after that, we offer you an MRI testing sometime. That's a special test. And after doing these testings, we refer you to the team of doctors, which involve the cancer doctors as well, the specialist nurses, we as your gynecologist, and there are X-ray doctors, we call them radiologists, right? So, and there are the team, the whole lot of team, they sit together, they decide about what will be best for you, because sometimes there are chances that that there can be other, or don't just skip that, just say whatever, like there is a camera test which we do to see inside of the womb if there is any lesion or mass. And then we also offer you sometimes these special scans, right? And after these testings, we refer you quickly within 2 weeks to the team of the doctors who decide the best management plan for you. Do you want me to explain you the type of treatment we offer generally for this specific condition? Yes, mostly we offer the removal of the uterus or the womb, and along with that, we also can think of removing the ovaries sometimes if there is any problem in that. Okay, or if the changes are advanced. So that team will decide and will discuss with you. Nothing will be done without your permission, right? So the removal of the womb can be done by different techniques. We can do it by a cut on your tummy. We call it open hysterectomy. Then that there can be a keyhole surgery. And then there are robotic surgeries as well nowadays. Yeah. So whatever you will decide, we will offer you that. Do you want me to explain these operations to you in detail? Yes, doctor, I would like to know about the keyhole thing. Yeah, in the keyhole, the with small, 1 centimeter or 0.5 centimeter, few cuts are made on your tummy. Through them, the long instruments, first you are put to sleep. First of all, let me say, clear it to you. And after that, we put you to the sleep, and we give the cuts, and then some instruments goes inside your tummy and we operate through these instruments. The benefit is that you have lesser pain, quicker recovery, and after going home also in a month or so, you are good to go for your normal routine work. So this is the benefit of this surgery. And after taking out the womb, we send it again for testing, the way we have tested the piece of the lining of the womb. Similarly, we will send the whole of the womb for the testing. Am I clear so far, Mrs. Smith? Okay. I don't want you to be scared of this. We are with you. If she panics or says something, just assess her once, then put your dialogues. If she's like, oh my God, will I die? Please do not think like that, Mrs. Smith. No one of us knows when we are gonna die, but we can always think positive. Yeah. And we are so hopeful that if the reports are the same, then the treatment is simple. But still, we do not want to put anything at risk regarding your health. So we would definitely like to involve all of a specialist doctor, team of doctors to care for you. Yeah, okay, thank you, doctor. Mrs. Smith, I am booking a next appointment for you with my consultant as well. And we would be pleased if, if you want to get somebody with you, like your family, friends, anyone, if want to come and join. And we will also inform you, the GP, to come. We can meet again, we can talk again and plan the things quickly so that we can proceed. Okay, understood?
Yes.
So you have already discussed.
Basically, we should after this, we should understand and try to think what exactly is more important that we have to tell. Like here, it was breaking the bad news and then just guiding her and just telling her.
Yes, yes, right. You
Yeah.
just have to tell her about the 2 week pathway. This will give you marks. MDT will give you marks.
Mm,
Hysteroscopy will give you
mm,
marks. MRI will give you marks. Understand?
mm.
Your written
Okay.
information will give you marks. Taking name of GP will give you marks. A combined meeting will give you marks with the consultant. All right. And
Okay.
your empathy will give you additional marks by the layman examiner, lay examiner. Okay. And by the role player also. The role player want to come back to you. And lay examiner will give you extra marks for empathy. Okay. And your written information is must. GP is must. Macmillan nurses are to be brought, that we have specialist nurses, generally we call them Macmillan nurses. They will also be there to help you and make you understand the condition better, right? We have some groups, so we will put you in touch with them. And if these kind of information, Mrs. Smith, I can very well see, most of the patients, they get distressed by hearing these news. And but we are there to help you. We have specialist doctors with us. If you want to talk about um, your stress, or if it is putting a stress on your mind, just please do tell me. No, I will be arranging a
Mm.
meeting with
Sounds
the
good.
mental health specialist. They talk and it benefits. Just say, take in the mental health specialist. Why not to take in? Because she is in a condition where she can have stress, right? Understood?
Mm.
Yes.
Yes.
So you have to tell that everything you have to cover. Everything. These drug allergy is a must point. You have to cover in all the station. Blood group, Jehovah Witness, you can skip also. Okay. And here you have to rule out all the risk factors. You have ruled out well. Okay. And if I may ask, were you pregnant before? Means she's pregnant now, right? So just mind these words very
Okay.
carefully, because they sometimes, when I gave the exam, so a lady who was very, very friendly with me, she had given a very tough time to all the candidates. All my friends were crying that, this lady was not letting us speak a word, and she was too friendly with me. I don't know what they were saying wrong, right? She was an obese patient, basically. So in the obesity part, they were mumbling and buffling here and there, and she mind it that you are calling me obese. So I never say anybody obese or overweight. I always say that it is your higher BMI, and this is the WHO who has made these criterias. Nothing to get offended about. And according to those criteria, you are at a higher risk. And the evidence also suggests, researches also suggest, if you lose your weight, the chances of regression of this problem are there. Not regression, but you'll have lesser problem in future. So just say that. Okay.
Mm.
Am I clear so far?
Yes.
So you have to take it very, very easily and naturally. You don't have to finish any station in the MRCUG exam. You just have to be constant and be calm. If you have
Mm.
a little basic knowledge, you can, even if you forget the percentage, that 10 to 20% it turns into cancer, just tell her that it has higher chances, that you said. I appreciate
Mm.
that. Just say like this. Nobody will mind whether you have told percentage or not, but people will mind if you have missed the safety bus points, if you have missed the 2 week pathway here, if you have not told her the three options of that she has the treatment choice of surgery. Okay. The surgery is the treatment for her at this stage, but we will do investigate. Mostly you will be offered a hysterectomy. If something else doesn't add up. All right. If something else doesn't add up, mostly you'll have a surgery. Surgery can be open, lapro, and robotics. So you can, everything will be discussed with you, and you'll have a chance for
You
this.
can just tell her we can discuss in the later appointment or next appointment about that.
No,
In
you
this way
give,
we
you
can
just,
make it short.
you don't have,
Okay.
no, don't say this. She'll say, okay.
Okay.
And suppose if the marks are lying in the risk and benefits of TLH, then you don't
Yeah.
know that. So you have to ask her, these are the options. Don't say that we will discuss in the next. Don't see, you have to be so much tricky, Bushra, so much tricky. You just have to, you have to
Make her
ask,
tell. Make
you
her
have
tell
to
what she wants.
ask and ask. Tell
Yes.
little.
Yes.
Tell the things which gives you marks. Don't tell unnecessary things. That is the funda of clearing this exam very quickly. Okay. Tell her the things which are required, my dear. Just tell her that these are the things for you. Then ask. Mrs. Smith, these are the options for you. Would you like me to explain that to you now? Do you want any extra information on that? That what are the types of surgery and what gives what benefit or risk?
Mm.
He'll say, yes, just tell me this or that. Then you have to say, okay, explain that.
Mm.
No, you don't know where
Okay.
the marks are. So you
Yes.
have to explain. And you have already killed that father thing that, tell them to mail you the papers so that we can discuss it. It can put you at increased risk of cancer, right? So you have killed
Mm.
it already. So whenever you get anything alarming, kill
Finish
it,
it off there. Yes.
finish it. Okay.
Okay.
Yes. Right. So these are the
Okay.
things. Yeah.
Mm. Thank you so much.
Most welcome. I hope this session has been fruitful to you all. And
Yes, definitely.
um, you need to get this idea in your mind that there is a way to complete the task. And like in the real life, we speak to the patient or deal with the patient. MRCOG is just going to give you such huge confidence. After part 3, you will be so confident in dealing with the patients. In India, in Pakistan, or in abroad, or in China, or anywhere in the whole world, wherever you are staying, you will be dealing with every patient very confidently. That I can write down. And this exam want you to prepare to that level. That confidence should come in you. Till the time your confidence will not come, you will not get through this exam. I want this confidence should come in